Hello, class. I'm going to continue with what we were talking about when we began discussing um, diabetes the other day. I think it's really important that you really get a good understanding of diabetes because, as I said the other day, this is a very common worldwide epidemic disease that has truly impacted our healthcare industry. And because many people who have been diagnosed with diabetes really don't have a good understanding of the disease and only think it's just, a problem with high blood sugar, which that's a very small part of it. They don't understand that without a good knowledge of the disease and how it affects every way of our life, they don't understand the potential for the serious complications that can occur over a long period of time, not necessarily overnight. And in order for us to convey that information to our patients, we really, as nurses, have to have a good understanding of diabetes. And I really want you to take this very seriously. Go over the PowerPoint, continue to read this chapter, because there are so many different elements in terms of getting the whole picture of what diabetes is about in regards to just the pathology, understanding hypo and hypoglycemia, how we diagnose diabetes, how do we treat it, what's the difference between type 1 and type 2, how do we teach our patients about controlling their blood glucose with diet, exercise, what happens when they get sick, and things that we take for granted as nurses, giving a simple sub-Q injection. You as nurses have been educated and taught how to do those injections in a very aseptic and correct technique, and we take that for granted. And yet some of our patients who have to give their own insulin really don't have that proper instruction on how to continue doing that in the correct way to prevent complications as well as a potential infection. So our goal is to really slow down the progression of all the micro and macro complications that may occur from diabetes, to prevent those very serious diabetic emergencies that we're going to talk about, especially DKA or diabetic ketoacidosis. And my goal here is to really help you understand the pathology, that when you see a patient with diabetes, you really want to take the time to look at every individual diabetic that you care for, to understand, when did they first get diagnosed? How much do they know about their disease? Do they understand their medications? Have them be a part of the control of their diabetes. If they want to give their own injections when they're in the hospital, that's a great thing to do. Or maybe it'll be a great time for you as the nurse to just kind of have them demonstrate how they do give their injections, and you provide the feedback, whether or not it's a positive or negative feedback, because maybe they've been taught incorrectly, or maybe they're just not doing it as well as they should, as well as, are they, injecting at the proper angle, are they cleaning the skin well, are they drawing up the correct amount in the syringes? Because many of our patients later on really do have difficulty seeing that line where they need to, draw up, 5 10, whatever amount of units is needed at that particular time. And another thing to kind of give them a little feedback on is whether or not they're doing their AccuChecks correctly, because we as nurses want to make sure ancillary personnel that works with us in the care of our patients is also doing the AccuChecks correctly. So I'm not trying to overwhelm you with information, because that's not my intent, because I know some of this information may be heard for the first time by yourselves, and that's why I want you to really take diabetes very seriously and really try to encompass and kind of absorb all this information, because the more you know about diabetes, the better nurse you'll be for your patients, because you will see this quite frequently with your patients. Not necessarily a primary problem while they came in, but it's very important to know that if they come in with a surgical procedure, or they come in with, say for instance, infection, you've got to know that they're diabetic, and you want to kind of see what their past history with their diabetes has been. Are they a type 1? Are they a type 2? How are they controlled? And then later on, kind of getting more information from that patient as regards to how much do they really understand about their diabetes. So just a little preface of what's ahead in regards to what information. I'm going to try to provide a lecture a day for you to kind of keep everything into one type of topic in regards to diabetes, and then hopefully that will keep everything fresh in your mind, and that everything won't be all kind of jabbled together. And I really want you to continue reading and going over your ICKY book, along with the PowerPoint, which will guide you as to what I feel has been important, and then listening to this. I'm trying to facilitate the learning as I've been doing in previous lectures, and giving you the opportunity to just listen and have this absorbed, and not make it more of a memorization, but making more as deep learning, and then being able to critically think and apply this information when you care for a diabetic patient. So as you can see up on this PowerPoint slide, we ended the class the other day with just kind of briefly discussing the pathology behind diabetes, and we kind of gave you a little, I gave you a little overall of thinking about the pancreas in regards to how it functions in helping to control blood glucose. And as I said before, this really is not the main reason why we have a pancreas. It's more of a digestive organ rather than an organ that helps with blood glucose control. But within the endocrine pancreas, we have about 1 million small glands in the islets of Langerhans, and of course, the two main types of cells that are in the pancreas are the alpha and the beta, okay? And the alpha cell is the part of the pancreas that produces the hormone glucagon, okay? And this is what stimulates that breakdown of glycogen in the liver and in the muscles, the formation of carbohydrates in the liver, and the breakdown of lipids in both the liver and the adipose tissue. And the primary purpose of glucagon is to decrease glucose oxidation and to definitely increase blood glucose levels, okay? And I talked about counter-regulatory hormones, and glucagon is the main counter-regulatory hormone, and I've kind of used that terms prior to the diabetic lecture, and we discussed this within the endocrine system, because we saw other hormones that were also counter-regulatory hormones. Not necessarily the main one like glucagon, but they did have a role in why those patients with oversecretion of that particular hormone caused the patient to manifest hyperglycemia. So that's basically what those alpha cells do in regards to glucagon secretion, okay? And then our beta cells produce insulin and amylin, and we of course know what insulin does. Very important to facilitate that movement of glucose across cell membranes into the cells, thus decreasing blood glucose levels. And that's how it normally operates and functions. When insulin is on board, it prevents that excessive breakdown of glycogen in the liver and in the muscles, and facilitates lipid formation while inhibiting the breakdown of stored fats, and helps move amino acids into the cells for protein synthesis, okay? And after insulin is secreted by the beta cells, insulin enters the portal circulation, travels directly to the liver, and then is released into the general circulation. So, and then that circulating insulin is rapidly bound to receptor sites on peripheral tissues, especially your muscle and your fat cells, or it can also be destroyed by the liver or the kidneys, okay? And as I said before, amylin is also secreted with insulin, and amylin is a glucose regulating hormone, obviously secreted by the beta cells, and affects postprandial, and postprandial is another word for post-meal glucose levels. It also impairs glucagon secretion and slows the rate at which glucose travels to the small intestine for absorption, okay? So, and basically what happens is insulin is, the insulin release, or the way in which the pancreas will secrete insulin, is primarily regulated by blood glucose. So if you have increased blood glucose, then obviously insulin is going to be released, and then by doing that, it will do and bring down those blood glucose levels, and that's what we mean by that term negative feedback, okay? So those are pretty much the two most popular cells in the pancreas, the beta and the alpha, but there's gamma cells and the delta cells. And the delta cells produce somatostatin, which acts within the islets of Langerhans to inhibit the production of both glucagon and insulin, and it also slows GI motility, allowing more time for food to be absorbed. So you really don't get that big spike in your blood glucose going up. So that's just a little review. And as I said before from this next slide, glucagon is the main counter-regulatory hormones, causes release of glucose from the cell storage sites whenever blood glucose is low, and that's probably about the level of about 70 deciliters, milligrams per deciliter. So when it gets to be around that time or below 70, that's when glucagon will be released, okay? So that's a little review of basically how the hormones work, especially the main ones, insulin, amylin, and of course glucagon, okay? And I just wanted to also remind you about within the small intestines, they actually produce hormones that lower blood glucose following the intake of a meal. And the reason I'm bringing this up is because we have medications that act very much like these particular hormones that come from the small intestines. And they're labeled as glucagon-like peptide 1, GLP-1. And there's also glucose-dependent insulinotropic polypeptides, or GIPs. And these are secreted from the small intestines to increase insulin release after a meal has been eaten. And the hormone stimulated insulin increases following an ingestion of a food is called a incretin hormone, or an incretin effect. And an injectable form of this hormone is called Byetta. And we'll be talking about this later on when we talk about medications. And that particular medication is used with patients who have type 2 diabetes, okay? So I just kind of want to preface that so that it makes a little more sense later on when we start talking about the pharmacological interventions that we do with our patients with diabetes. So kind of put that in the back of your brain, and it'll make more sense when we begin talking about the medications, okay? As you can see from the slide, if you look at the insulin physiology, basically active insulin is a protein, and proinsulin is an insulin precursor, okay? And this active insulin, that is a protein, is actually made up of about 51 amino acids. And it is initially produced as inactive proinsulin, a prohormone that contains an additional amino acid chain. It's a C-peptide chain, okay? And proinsulin is actually converted into active insulin by removal of that C-peptide chain. It's actually cleaved or kind of cut off in the liver, okay? So that's how that works in regards to the way insulin is secreted. And insulin is like a key that holds locked membranes to glucose, and it kind of is the key that actually moves that glucose into the cells to generate energy, okay? And really think about that long and hard, because we're talking about what insulin does. And, you know, it's one thing to actually move it out of the vasculature and put it into the cells. But why is it doing that? It's doing that because it's really necessary that it has that glucose for cellular energy. And without that glucose moving into the cell, think about how your patients are when they have hyperglycemia and a lack of that insulin or that glucose into the cells. They're fatigued, their energy is depleted, so it makes a little bit of sense. So as we go over these things, I want you to take each one very seriously, because then it gives you a better understanding of exactly what's happening with a patient that actually has diabetes. And as you can see, the liver is the first major organ to be reached by insulin in the blood. And then we talk about glycogenesis versus glycogenolysis, okay? And I did put up all those G words for you on Wednesday, and hopefully you look at those, because they are a little bit similar in many ways, but each one is distinctly different and kind of provides a term for a certain process that takes in regards to glucose control. So please, I want you to make sure that you're looking at those, okay? Obviously, you know what glucagon is. That is the major counterregulatory hormone that comes from the alpha cells. And then we have glycogen, and that's actually just a fancy term for when the body stores glucose in the liver or the muscles. And then, as you can see from the PowerPoint slide, glycogenesis, that's the formation of glycogen from glucose. And then glycogenolysis is the breakdown of glycogen back to glucose. So those terms are very important that you understand, because you definitely will see them on the test. And I've already talked about glycogen. It's stored glucose in the liver. It is broken down by glycogen or glucagon when the blood glucose is low. And that breakdown of glycogen to glucose is called glycogenolysis. Okay? And the conversion of amino acids into glucose is that is an error on the PowerPoint slide. The conversion of proteins to glucose is called gluconeogenesis. So just want to make sure I don't want to confuse any of you. Okay? Like I said, they can all get a little tricky. That's why it's important that you reread these and understand what these G words mean, because this is just how our bodies work. In trying to keep those blood glucose levels at an even keel. And here's some additional terms. Ketogenesis, as I said, gluconeogenesis, the conversion of proteins to glucose. And then this simply states about how the normal healthy pancreas works. What the intention is, when we have a person who becomes a diabetic, we try to mimic that pancreas to act just like it would under a normal healthy condition. Normally, the pancreas secretes about 40 to 50 units of insulin daily. Low levels, even fasting, it just secretes a very, very minimal amount to keep those blood glucose levels at an even keel. And then obviously that amount will be increased definitely after eating, and we call that prandial time. Okay, so basically what occurs is that 40 to 50 units of insulin is secreted daily directly into the liver circulation in pretty much a two-step manner. About 10 minutes after you eat, insulin is secreted, followed by an increased release that lasts until blood glucose is normal. And usually the blood glucose stays somewhat elevated for about a couple hours, and then it begins to return to normal levels, okay? Insulin does affect metabolism. It affects cellular processes in different body tissues and organs. And that metabolic effect that insulin brings is it actually stimulates glucose intake in skeletal muscles and in the heart muscle. And it also suppresses liver production of glucose and very low density lipoproteins. And within the liver, it actually promotes the production and storage of glycogen, or glucogenesis. At the same time, it inhibits glycogen breakdown into glucose, and we call that process glycogenolysis. And increases protein and lipid fat synthesis and inhibits ketogenesis, conversions of fats to acids. And it also causes the conversion of proteins to glucose, and or inhibits the conversion of proteins to glucose. And within the muscle, insulin promotes protein, glycogen synthesis, and in fat cells, it promotes triglyceride storage. So that's a lot of work that insulin does than just, keeping blood sugars at an even keel or at a normal level. You can see the effect it has on metabolic processes within the body. And this is just that picture stating what I just told you about how the insulin will go to the liver first in portal circulation, and that's where that pro-insulin is cleaved, as you can see from that like semicircle, how it's cleaved from that amino acid and then becomes an activated insulin. And you can see target cells, adipose tissue, muscles, and other insulin-dependent sites to kind of provide that doorway for glucose to get into those cells to create energy. Okay. And these are factors that increase incidence or severity of diabetes. Certain medications, what race you are, if your blood pressure is high, stress, if you're over 65, pregnancy. We're talking about gestational diabetes at that point, high cholesterol, obesity, family history, and inactivity. And don't forget, we really look at a person who's definitely profiled as one that we would call metabolic syndrome. Okay, I'm sure I've said this term before. I think we discussed it somewhat in the cardiac lecture. We call it metabolic syndrome, or also syndrome X. And people that have these manifestations or metabolic factors are known to have an increased risk for developing type 2 and also cardiovascular disease. And these are abdominal obesity we look at, men 40 inches or larger and women 35 inches or larger. And we're talking about hyperglycemia, blood sugars 100 milligrams or more, or even hypertension, where we see people with systolic blood pressures of 130 or more, or their diastolic above 85. And also people that definitely have hyperlipidemia, where their triglycerides are over 150 and their HDLs are less than 40 for men and less than 50 for women. So if any of those situations occur, research has shown that that person who does fit the image of a metabolic syndrome person will very much be at risk for acquiring like a type 2 diabetes. All right, we're going to talk about the types of diabetes. And I'm sure you've heard the terms before, but I just want you to get a real good sense of the pathology involved in persons who are diagnosed with diabetes. And it's very important to know whether or not they're a type 1 or a type 2. And I always like to get a sense of how long that person has been diagnosed with diabetes, because then you can kind of surmise in your mind that maybe if they really haven't been having the best chances of, being within a fairly, good control, then you might kind of want to detect and look for signs of some of the micro or even macro vascular changes that may have occurred due to the fact that they just really have not been totally compliant in keeping those blood glucoses under control. The first one we're going to talk about are your type 1. And type 1 diabetes is more of an autoimmune disease in which beta cells are destroyed in a genetically susceptible person, okay? And your type 1s are probably the least common, or the smaller group of people that have diabetes. The immune system kind of fails to recognize normal body cells as self and starts destroying them. And there's really no exact cause of why this happens, but sometimes we see it with certain, tissue types, Maybe someone has just had a viral infection, changes cell surface receptors. Maybe they've had the mumps, and these all can later on initiate some kind of destruction of the pancreatic beta cells. Can most often occur in childhood and adolescence, but it may even occur at any age, even people in their late 70s, 80s, or 90s. Not very common, but it could have happened. So let's kind of discuss what happens in somebody with type 1. Obviously, it's characterized by hyperglycemia, meaning these people are going to have high blood glucose. And at this point with type 1, there is absolutely no pancreatic function at all in regards to insulin secretion. They are not secreting any insulin whatsoever, okay? And usually the hyperglycemia is much more profound with a type 1. And with hyperglycemia, there's also a breakdown of body fats and proteins, and the person also develops ketosis, which is the accumulation of those ketone bodies, okay? Those are produced during oxidation of fatty acids. So as I said before, your type 1 patient with diabetes will absolutely have no insulin being produced. No insulin whatsoever. That's why you don't see people with type 1 on any type of oral hypoglycemics, because those drugs kind of boost the pancreas to secrete more insulin. And when there's no insulin being secreted, there's no need to put those patients on any hypoglycemic drugs. That's why type 1s are fully dependent on insulin to control their blood glucose levels. And usually this process of the autodestruction occurs slowly with the onset of hyperglycemia when about 80 or 90% of the beta cell function is lost. And besides the lack of insulin, there is also a relative excess of glucagon. And remember what glucagon is. That is what comes from the alpha cells. That's the counter-regulatory hormone. So that also further escalates the blood glucose and causes further hyperglycemia. There is a genetic predisposition to someone acquiring type 1 diabetes. And about anywhere from 1 in 400 or 1 in 1,000, the child of a person with diabetes has sometimes a 1 in 20 or 1 in 50 chance of acquiring type 1 diabetes. And usually if they would do some genetic testing, they would see a genetic marker that is found, which increases the susceptibility of acquiring type 1 diabetes. Sometimes the environmental factors, which may be a cause, could be a viral infection, chemical toxin, those kinds of things. But we don't really have a precise reason why someone does become a type 1 diabetic. It just happens. So what are we going to see this patient look like that has type 1 diabetes? They obviously have a lack of insulin to transport glucose across the cell membrane into the cells. So those cells are going to be lacking that glucose and really lacking the ability to generate energy, because the glucose is going to stay in the vasculature and just continues to decrease. So with that high blood glucose, okay, and glucose molecules are very big too. Hyperglycemia will cause serum hyperosmolality, drawing water from the intercellular spaces, pulling it into the general circulation. So because of that, it's going to increase blood volume, it's going to increase renal blood flow, and the hyperglycemia acts as an osmotic diuretic, thus increasing urinary output, and that's what we term as polyuria. Poly means many, urea has to do with urine, so they're going a lot. Almost like a diabetes insipidus. They're just urinating a lot because now that hyperglycemia has really, you know, kind of caused the pulling of water from the intracellular spaces back into the vasculature. So when the blood glucose levels exceed the renal threshold for glucose, and usually the renal threshold, and what that means is the limit to where the renals or the kidneys are able to hang on to that glucose and then reabsorb it back into the vasculature rather than letting it be excreted in the urine. And that's usually about 100 milligrams per deciliter. So then if it exceeds that, say if a person's blood sugar goes up to 400, the kidneys can't handle all that glucose and they'll just let it be excreted in the urine. And so that's why when people start to develop glycosuria, meaning glucose in the urine, then it's quite evident that their blood glucose is probably at least over 180 milligrams per deciliter. And sometimes books say the renal threshold is maybe 220. So it's anywhere in that range from about 180 milligrams to 220 milligrams as to what the renal threshold is. So this is why they develop glycosuria, or the secretion of glucose in the urine, because glucose should not be in one's urine. Okay, you should not have a high level of glucose in the urine. And with the decrease in intracellular volume and the increase in urinary output, this is causing a problem of dehydration. Mouth becomes dry, thirst sensors are activated, and this is why the person really starts to get incredibly thirsty, and we call that polydipsia. Okay, and because glucose can't enter the cell without insulin, energy production decreases. So this lack of energy, the person is trying to get their energy from another source. So what happens is the person starts to eat a lot more food, and this is where we get the term polyphagia, where they're extremely hungry because they're trying to provide a source of energy. And so despite the increase in the food intake, the person loses weight as the body loses water and breaks down proteins and fats in an attempt to restore energy sources. So the person becomes very malaise, fatigued, and just does not feel well. And another manifestation that can occur is blurred vision, osmotic effects that cause swelling of the lenses of the eyes. And this manifestation of hyperglycemia can be either slight to severe, and obviously without any whatsoever secretion of insulin, people with type 1 diabetes will need an external source of insulin. Okay, and then, you know, we're not going to get into the specific types right now until, you know, we get to medications, but you know, some people definitely need, you know, mealtime insulin, or some people need more of a long-term insulin that's going to kind of get them through the whole day. And sometimes these patients may be on both types of insulins that work a little bit longer than just a short-acting insulin. So that's type 1 diabetes, okay? So let's kind of talk about type 2. It's a fasting hyperglycemia that occurs despite having insulin on board. Now, they're still secreting insulin, but it's not enough to keep those blood sugars under control. The patient still develops hyperglycemia. It can occur at any age, but often seen in middle age and older people. And this is where we talk just about the metabolic syndrome. People were candidates for that. And this is why we try to teach the community that you can avoid becoming a type 2 diabetic if you control, your weight, your blood pressure, your triglyceride level, your LDLs. All those things factor in as to making the person more vulnerable to becoming a type 2 diabetic. It is the most common form of diabetes. Heredity can play a part in acquiring the disease. And the level of insulin that is secreted or produced really varies from person to person. The liver produces more glucose than normal, and really there is some available insulin on board, but the function of that insulin is impaired by insulin resistance in all the peripheral tissues. And so dietary carbohydrates are not metabolized well. Eventually the pancreas secretes less than adequate amounts of insulin. Now there's still sufficient insulin production to prevent the breakdown of fats, causing the results of ketosis. And remember, type 2 diabetes is the non-ketotic form of diabetes mellitus. Okay. And the major factor in the development of type 2s is cellular resistance to the effects of insulin. And this resistance is increased by obesity, inactivity, illnesses, medication, and increasing age. And with obesity, the insulin has decreased ability to influence glucose absorption and metabolism by the liver, skeletal muscles, and adipose tissue. Hyperglycemia increases gradually and may exist over a long period of time before it's actually diagnosed. And that's one thing to remember. Some of these people with type 2 diabetes do not even know that they have it. Sometimes just the matter of losing weight and increasing activity, especially if these people are pre-diabetics and they begin to change their lifestyle, may avoid becoming a true type 2 diabetic. Hypoglycemic meds are given when lifestyle changes are not sufficient. So if the person does decide to lose weight and, start exercising, maybe bring their blood pressure down, may not necessarily mean that they won't become a type 2 diabetic, but it is worth a try. The risk factors for becoming a type 2 diabetic may be having a history of diabetes as in parents and siblings, and again, all those unhealthy lifestyle practices of obesity, physical inactivity, and also being from a certain race or ethnicity. Okay. Women who are also have had histories with gestational diabetes, meaning when they're pregnant, they develop this type of diabetes during pregnancy, but after they have the baby, the diabetes pretty much goes away. Again, women that have polycystic ovary disease and women that have babies weighing over 9 pounds. Hypertension, as I said before, and then HDLs, we want to get higher, and ones that are over 35, and triglycerides that are over 250. Again, labeling these people as metabolic syndrome. That hypertension, visceral obesity, decreased levels of HDLs, increased triglycerides, increased C-reactive protein. Remember, we talked about that in cardiac. C-reactive protein is more like a marker for the indication of inflammation. If fasting blood sugar is over 110, and increases the risk of diabetes along with chronic heart disease and stroke. With type 2 diabetes, manifestations are slow, and the hyperglycemia may not be as severe. They will have polyuria and polydipsia, but polyphagia is not often seen, and weight loss is uncommon. They can still have blurred vision, fatigue, paresthesias, and skin infections. Okay, so those are kind of the differences between type 1 and type 2. On this PowerPoint slide, we have gestational diabetes, and I'm not going to get into that. I know you will study that or have studied much of gestational diabetes during pregnancy. Another kind of diabetes that is not on this PowerPoint slide is called MODY, capital M, capital O, capital D, capital Y, and that's a acronym that stands for maturity onset diabetes of the young, meaning any adult under the age of 25 that develops any type of diabetes. And this could be caused from actually a genetic problem of mutations that occur in the single gene. It's not very popular, but it is a different type of diabetes, and I'm just giving you this information that you may hear about, as you graduate and become a nurse. You'll say, oh yeah, I remember hearing about that in nursing school. I'm not going to give a lot of detail because the person that has this is very hard to get a hold of, but it is a different type and a very uncommon type of diabetes. Other specific conditions resulting in hyperglycemia could be genetic defects, as I just talked about with Modi. And then, of course, we talked in quite detail about all the endocrine disorders that are counter-regulatory hormones, your growth hormone, your cortisol, your norepinephrine and epinephrine, and then also some chemical-induced conditions, as well as infections. And these are just kind of a summary of type 1 and who would fit that bill in becoming a type 1 diabetic, usually under 30, manifesting the 3 Ps of polydipsia, polyphagia, and polyuria. I want you to read these over. I want you to understand the pathology of why these 3 Ps happen, not just memorizing, oh, the patient's suffers from polydipsia. Oh, whatever that is, I just know it's polydipsia. I want you to know why they have polydipsia. Why do they have polyphagia? And why do they develop polyuria? Why are they in a state of ketosis all the time? Insulin is required to manage their diabetes and their high blood glucose levels. This just shows you where you would see the range of their particular glucose. Easily becomes hyperglycemic, and there are large amounts of ketones in the urine. Along with glucose or glyceria occurring, they're also going to start seeing ketones. And that's why we really want to later on discuss, when patients get a little bit more acceptance of their disease, of why it's so important that they do AccuChecks 4 times a day, before meals and at bedtime. Because, we wouldn't want somebody who has a large amount of ketone in their urine to go out and exercise, because the evidence of ketones in the urine really proves that the person is not well controlled with their blood glucose. So that's why that's a very important piece to definitely assess on a daily basis to determine if it's safe for that person to go about and do things that may require more energy. No, it's not. Ketones really tells you a lot about the state of health of your person or your patient. Okay? Just to talk a little bit about diabetes in the older adult. Most older adults think that it's other issues that are occurring and not really a problem with type 2 diabetes. About 23-24% of the U.S. population over 60 have diabetes, and this will continue to increase because the incidence of the diabetes increases with age, and because the number of people over 65 is increasing. And the physiological changes of aging may be masking a lot of the manifestations. People may not see polyuria and thirst in the older patient, as a sign of diabetes. A lot of them think that, it's just the normal aging process, and unfortunately with polydipsia, they don't have as good a thirst sensation, or to kind of say, the body says to them, hey, you're thirsty, you need to drink more. If it's very often ignored in the elderly population, leading to dehydration and electrolyte imbalances. And that's where too many elderly patients end up, becoming quite dehydrated because they don't really have that thirst sensor kick in, and many of them develop UTIs and later on can become septic from that. Some of them go to the bathroom a lot and they think it's urinary incontinence, where really it's polyuria. Decreased hunger and weight loss kind of is the reason why polyphagia is ignored. Many of them feel tired all the time and depressed, and with hypoglycemia, as they get older, they really have more of a difficult problem in the ability to sense that their blood glucose is getting very low and in dangerous parameters. And usually until it's real serious is when the person will think, oh, something is not right with my blood glucose. Many of them have peripheral neuropathies, and they blame it on arthritis, and a lot of them have peripheral vascular disease that cause impaired mobility, and many of them have diabetic retinopathy, and of course maybe undiagnosed hypertension. So that's why many times this goes on, and they don't even realize that really they're demonstrating signs and symptoms of diabetes. Alright, so that's type 1. And then here's the PowerPoint slide on top 2 that kind of contrast exactly what manifestations you're going to see. School age to older, obese, many of them that have that metabolic syndrome. Your type 2s can be managed with oral hypoglycemics and diet, rarely develop ketosis, mental status changes, and we watch for dehydration such as HHNS. That's one of the diabetic emergencies that we're going to talk about later on. I'll conclude this lecture, and then the next one we'll start to discuss the glucose homeostasis, and then discussing what occurs with the absence of insulin. Thank you for your time, and if you have any questions, please let me know. I'd be more than happy to answer anything that may not be clear or presented in an understandable nature.